So I'm going to be talking about, I'm going to be bringing medical education training into the discussion slightly, but in particular I'm talking as co-PI on a project also funded by the National Institute of Health Research, which is called Care Under Pressure, which looks at doctors' mental ill health. So I'll be thinking about mental ill health of a very particular group. So the first thing I'm going to say a little bit more, build on what Chris has said, something about the changing face of general practice and the impact that that has on general practitioners, GPs. And then I'm going to sneak in some findings from our current research project and end by just starting the conversation about how medical education might help. So this talk is very much focused on doctors, but of course it's the mental health of doctors is important to doctors and their families, but it's critically important to patients, and I hope that comes through strongly through the talk. So this is the theory. This is how we think general practice is supposed to work. People in the community, if they suffer ill health, can visit a GP who will either be able to work with them and manage those problems themselves, or they can refer on to a number of different professionals, whether they're physiotherapists, talking therapies, social care of some sort, so that that patient is seen by the right professional in a timely way. So that's the theory. But we know from many sources, and we've heard today, about the increasing demand for GP services. And this is a really important report from July 2014. And these bullet points are the real headlines from their executive summary, but it's saying that growth in the GP workforce hasn't kept pace with the demand for the services or with the population growth. And that means that the GP workforce is under considerable strain, and as the demand increases, the numbers of GPs are not increasing. It's actually proving quite difficult to get GP trainees coming through the pathway. And I mean, there's almost a vicious cycle going on because that puts more pressure on the GPs in practice. So if we go back to my nice simple diagram, we're going to layer on some complexity now, because we've got a lot of people in the community wanting to access GPs. And those patient problems are not easy. These are complex problems. Older people, stress, anxiety, addiction, malnutrition, obesity, poor housing, homelessness, domestic abuse, etc., etc., etc. And you can see how this links to the themes of this conference, how the nature of the patient problems might be changing over time. They've got a short time in which to try and resolve these problems. And some of these therapies are either not available, or the GP knows there's a very long waiting time, so if they refer them to these specialist services, that may not provide the timely service that they might hope. And sometimes some of the problems will then come back to the GP. So even if they do refer, they will come back to them unresolved. So there could be that frustration. And I know through the DeStress project there was talk of the frustration felt by GPs at sometimes being the gatekeeper, the person who had to decide whether people could access certain funds. So all of this is putting pressure on GPs, either workload pressure or some frustration in the nature of their role. Now this is another really interesting study. This one's Doran et al. From 2016, so relatively recently, and they interviewed GPs who were leaving GP practice. And they talked about these cumulative aspects that developed into a decision to leave being a GP. The analogy, which I'm not sure if I like or not, is boiling frogs. The idea being that if you drop a frog into boiling water, they hop straight out. If you put them into warm water and gradually raise the temperature, they will stay in that environment for much longer. And the analogy made in this paper is that that GPs, this system that they've been working within, the temperature's been rising over time. And interesting, some of the things they're talking about, you know, increase additional tasks as well as the workload. It's the nature of the work which changes what they thought being a GP was about. They've less time with patients, and that affects perhaps their sense of professional autonomy, values. So it affects their job satisfaction. And one bit that I thought was really interesting, it was also the negative media portrayal of the work they were doing, and that was making them feel vulnerable to burnout, ill health, and ultimately towards decisions of GPs. So if you're interested in this area, that's a really neat paper to look at. So there is undoubtedly a problem with doctors' mental ill health, not just doctors, across healthcare professionals, but our research has focused on doctors for various reasons. Talked about issues of recruitment and retention, but I just wanted to mention absenteeism and presenteeism. So absenteeism when doctors are sick and are not at work, either for a short time or a longer period, and of course the impact that makes on patients, but also on other people within the healthcare teams. But also presenteeism, arguably just as bad, doctors being at work when really they're unwell and perhaps they shouldn't be at work. And unwell doctors, increasingly there's a literature that shows unwell doctors can harm patients. This quote's from the House of Lords Select Committee. It says, "We're concerned by the absence of any comprehensive national long-term strategy to secure the appropriately skilled, well-trained and committed workforce that the health and care system will need over the next 10 to 15 years. In our view, this represents the biggest internal threat to the sustainability of the NHS." So quite a strong quote there. So moving on very quickly to give you some insights into the research that we're doing. So this is a project ongoing. We finish in April. And we're trying to understand, first of all, how mental ill health in doctors develops. So this isn't just GPs, this is all doctors and all career stages, and of course my personal interest, particularly those earlier stages. So we're interested in how it develops, and we're interested particularly in the interventions that people put in place to support, develop, retain doctors. We're interested in the ones that work, the ones that don't work, why they work, why they don't work, things we could be doing, things we could be doing better. So that's the research, and it's in collaboration with colleagues in Hull and in Oxford. This is the team. I show this because they hate me showing their photos, so I always do. And this is our published protocol. So this is showing what we are doing, but not with the results at this stage. And just to give you a sneak preview, it's interesting, we've talked about root causes quite a lot in the sessions. That's the thing that's come through for me. So I think what we're doing gives some insight into root causes for doctors at least. So here's an insight, just a couple of insights. Here's one. When doctors have more responsibility but less control over their work, they may feel undervalued and frustrated, or experience a tension between their expectations of what it means to be a doctor and the daily experience of clinical work, leading to them to experience less meaning in their work, which may lead to mental ill health. And it was interesting before lunch when people were talking about worthwhile work and meaning. Because that's my particular interest, I've been thinking about the implications of some of these things for medical education, whether that's undergraduate, postgraduate or beyond. And I think we need to provide learners with much more opportunities to discuss these tensions and the compromises that people make, the reality of the daily experience. I also think we could empower learners more, give them opportunities to, even if it's a tiny change, have some kind of control of making things better in their mini environments. Here's a second finding. So when formal and informal opportunities for collaboration and dialogue are available, doctors feel a greater sense of connectedness to their colleagues and their profession, leading to improved learning and support and an increased capacity to work under pressure. So again, some themes with this conference, thinking about the groups, the connectedness, being part of something worthwhile. Implications for medical education, small group activities. This is something we already rely on very heavily in our undergraduate program at Exeter, but small groups are so important to build a sense of belonging, whether it's to a group of students or whether it's to a GP practice, whether it's to the profession of medicine, but small group discussions. And then being able to prioritise opportunities to engage in mutual learning and support. And I think that's particularly hard for people who are no longer officially trainees, you know, when they are fully qualified. How do you protect time and prioritise it to engage in those discussions, etc.? So in summary, general practice is undoubtedly changing. It's broader, it's more complex, there's a higher workload. I think Chris's point about the wider healthcare team is an important one, because something I haven't talked about, which is undoubtedly happening and offers lots of opportunities, is the roles that other people within that healthcare team can take on and are taking on. But certainly GPs are providing care under pressure. But, I mean, I think some of the discussions through this, but certainly through our research, I think the more nuanced our understanding of what the problem is and what the strategies to address the problem, which ones are working, which ones aren't working, why are they working, when are they working, that's going to help us to understand what to do next. And I just wanted to introduce the idea that medical education, but all education, has an important role to play. Thinking of medical education, we need to prepare medical students for the realities of practice, and I'm thinking about what Richard said about the consultation and how we prepare medical students to become GPs and have those really productive conversations with patients, but also supporting trainees who have qualified through the various transitions in their career, and finally sustaining GPs throughout their careers. And that word sustaining, you know, keeping them going, keeping them energized, keeping them invigorated in their practice of medicine. So a quick thank you to my colleagues on the Care Under Pressure team, and to acknowledge the funding and provide some contact details there. And those are the references that I've cited in the talk. Thank you very much.